That's my hospital, BLK Super Specialty Hospital, New Delhi, and this is my lovely team back home. Um, and I have no specific disclosures to make here. So this is what I have done. I have kept a little bit of a preface about the talk. We'll talk about some historical aspects. We'll understand the concepts of flagging. We'll also look at what are the slide review criteria, or what is otherwise called slide review rules. We'll talk about validation of slide review rules. And the last but not the least, which is also very, very important in today's day and age, especially for high throughput laboratories, concept of automated selection and release of reports. And finally, some summary and conclusions. So let's just quickly peek into the history part of it. And I believe that I have students around with me. So the first question to any one of you, whosoever volunteers, and the question is, cell counters are based on one or more of the following, except. So if there are four choices, impedance, light scatter, sonology, and image analysis. And the answer would be anyone? Any of my students here?
Sir, I guess sonology.
Sonology. So the answer is sonology, indeed, because we know that, if we look at the hematology analyzers, most of them are based, in fact, all of them have impedance as one of the methodologies. And then some of them have light scatter as one of the methodologies. And there are others which have image analysis also as the methodology. Now, sonology principally is something which is not available in any of the analyzers that is used in a classical laboratory. But in today's day and age, sonology has become a part of our, Fitbit kind of a thing that we use on our arms, or the Apple watches and stuff like that. They have now started putting up transducers, and they're trying to see if we can get the CBC kind of a done on that watch itself. But again, that I'm sure it'll take a little more time. So let's move to the next question. All of the following people possess patents for hematology or hematology related cell counters, except Wallace Coulter, Joseph Coulter, E.A. Epstein, and Paul Ehrlich. Any guesses?
Sir, maybe Paul Ehrlich.
Wonderful. Again, spot on. So Wallace Coulter and Joseph Coulter were brothers, and they were the ones who gave you what is called the Coulter principle. And E.A. Epstein was one of the scientists who worked for Technicon and gave you the fluorescence-based flow cytometry platform for hematology analysis. Paul Ehrlich, of course, got many other awards and had many other patents to his credit, primarily related to staining and lots of other things other than this, but he was not the one who actually got it on the hematology analyzer part of it. All right, so great, two good questions and fantastic answers. So if we look at hematology automation today, we have two general principles. The two general principles which most of us use in our analyzers. One is electronic impedance or resistance, which we call it, and the second one is light scatter properties. And I'm sure most of you would know this. There's something called Coulter principle, in which what all we do is we dilute the sample, we put it through the vacuum and the pressure, and we also make it pass through a hole through which the current will pass, as long as this is a good conductor of electricity here. And then once the cell comes in between, it becomes a bad conductor of electricity and impedes the current between these two, and that helps you to identify it as a pulse. So this is how it works. So as you can see, every time this green dot passes through this aperture over here, or the hole over here, you get a kind of a pulse. And all these pulses are then kind of collected together, and depending upon the size of the particle, the pulses will give you different sizes, different amplitudes, and you're able to actually size it out based on that. Now, this again is one of those images which is extremely important for all of us. Why? Because we need to realize how a classical hematology analyzer works. And mind you, most of the hematology analyzers work on this principle only, as I'm showing you in front of you. So how does it work? You have a sample which is aspirated into the hematology analyzer. And I told you there is a system of pressurization and vacuum. So it ensures that the sample gets aspirated by, kind of sucking it up. Once it gets sucked up, it gets divided into two distinct parts, as you can see in this picture over here. So one part of it goes into what is called the RBC chamber, RBC or platelet chamber, and the other one which is called the WBC chamber. So in the RBC chamber, the the white cells are kind of ignored, and you're only looking at the red cells and you're looking at the platelets, and it's primarily based on impedance. And in this, eventually the sample also gets into what is called the hemoglobin channel, where it's made to react with sulfluoryl sulfate in majority of the instruments today. And then from there, you get your hemoglobin values. Parallelly, you also get your RBC counts from the RBC pulses as well as the platelets, and you're able to get the values from there. Nowadays, what has happened in newer analyzers, they have eventually connected it back into a retic channel on this side, and then found out reticulocytes from the RBCs, remaining RBCs, and also done a lot of work on the platelets on the retic channel. We'll not get into that detail at the moment. Now, the second part of it is the WBC chamber. In the WBC chamber, the red cells and the platelets are useless. So obviously you want to, kind of lyse them. You want to throw them out. So you use a lysing agent, which is kind of destroying it further and ensuring that those cells are taken away from the analysis. And all you have left with you is the white blood cells, which depending upon the analyzer you're using, you might have, almost a near native state, for example, in a classical Coulter analyzer, or you might strip them off, the cytoplasm and dye them up, for example, in Sysmex analyzers or Mindray analyzers or any of those analyzers which are primarily fluorescence based. And basis that, you can eventually get your white cell counts and you can also get your differentials. So depending upon whether you are actually using only the impedance or using impedance along with fluorescence or any other mechanism to identify all your cells, the analyzer can be a 5-part or a 3-part analyzer respectively. All right, so therefore, electronic resistance or impedance, as I said previously, and I showed you also in the pictorial, that the cell will pass through the orifice, it will displace its own volume, which will create a resistance between the two electrodes. And of course, RBCs and platelets, as I showed you from the previous diagram, are counted together, and you have the cells passing in a single file due to what is called hydrodynamic focusing. Now, these are some pictures which I show every time I talk about hematology analyzer, and I'm sure most of you would not, even know what it is all about. So this is the cigarette, kind of paper, which is kind of foil kind of a paper, which is covering the cigarettes in most of the cigarette packs. And this is a thread and a needle, and one must be wondering, why am I showing you all the three? The three I'm showing you primarily because this is what was used for the first time to create what is called the aperture, by create an aperture by the Coulter brothers. And this was the first aperture. And these were the Coulter brothers, of course, during their younger days, and much later when the Coulter Foundation was actually established. So these were the Coulter brothers. And of course, this man got majority of the limelight, the Sir Wallace Coulter, and there's an award in his name also called the Wallace Coulter Award from the ISLH, Interestingly, when Coulter brothers went to the patenting authority and they asked them that, they would like to patent the aperture, they were told that you can't patent a hole. Obviously not. And then eventually they went ahead, did some litigations and stuff like that. And eventually they really got the patent. But remember, they were not the first people to get us the cell counts. The first cell counts actually came by fluorescence flow cytometry. And this was by going capillary, the cells going through a capillary tube and passing through a light beam. And this was actually given by this gentleman here by name E.A. Epstein, which I asked you in the question previously. And he was one of the scientists who used to work for Technicon, and he got a patent for this, which was published much earlier. So these are the graphics which were from those patents, and this is still utilized in some of the hematology analyzers. For example, Advia, for example, even Mindray and Sysmex analyzers have these possibilities of using similar kind of scatter properties for red cells as well. Now let's quickly understand why did we want to have a cell counter. So the aim of the cell counter was pretty simple. We wanted to reduce the manual labor, and we also want to reduce the work of reviewing the smears. I'm sure as when you are posted in a clinical pathology or a hematology laboratory, most of the students get bogged down by a lot of smears which come onto their tables to review. And especially if you have a 3-part analyzer, you're left with no choice but to review every smear. And the problem is when you try to use a machine and you try to reduce the number of reviews that you want to do, you have only one fear, and that fear is you don't want to miss a case, right? And that is why you have to ensure that the slides are made only in such circumstances where they are relevant, and you should also ensure that you do not miss a case whenever there is a case which needs to be seen by us. So flagging in its simplest term means checking the slide, right? So as long as we have, so flagging as a term is something which is to be kept in mind, is basically to check the slide. So let me ask a question again. Terminology of flagging in a cell counter signifies what? Does it mean putting flags to the vendor on the instrument? Methodology of alerting the user for any kind of a review? Alerting the user regarding the change of reagents only? Or alerting the user of potential impending electrical short circuits? So any answers? I think I already gave the answer. The answer is pretty simple. This is methodology of alerting the user, right? So it's, yeah, the B is the answer. It's the methodology to alert the user for any kind of a review. Now, when you talk about flagging, there are many types of flags which come from an analyzer, right? So you have what is called a condition flags, which basically describes the population as normal or abnormal. And here the analyzer is pretty, kind of convinced that this population is absolutely normal because it would have been in an area which was defined by the company using many samples before they actually got the instrument into picture. And then you have the ones which are called suspect flags, where the analyzer understands and identifies abnormal cells in a certain area in the instrument, which potentially can be abnormal. For example, it might give you a blast flag, it might give you an immature granulocyte flag, or it might give you a band flag, it might give you a variant flag. And remember, when it gives you a review slide flag or an R flag, you're always expected to review the smear. Then if you look at other flags which can come out, more definitive flags, that's what we call them. You can have a flag of nucleated red cells, especially in today's new age hematology analyzers. You can have, flags which can flag the macrocytic red cells, dimorphic populations, etc. You can also have flagging defined on your lab limits. For example, you can decide that I can have a critical alert at a certain number, and that instrument itself will give you a value of a critical alert, right? And sometimes you might also want the analyzer to let you define as to how and when you should be having an information for review. So all these are possibilities which one can potentially have with respect to flagging. And I'm sure most of you, if you actually go back and check your instruments, you would realize that from the instrument printout itself, sometimes you can get all of these flags. And mind you, these flags are instrument specific. So not every instrument will have similar flags. For example, this asterisk mark in Coulter Analyzer talks about exceeding the instrument threshold. Similarly, if it's plus, that means it exceeds the linearity range. Similarly, AL means action at a low limit. Similarly, C means critical. R means region flag, or sometimes it can also mean a review flag. And then P sometimes means partial aspiration. And then, of course, you have so many codes which are, again, dependent on different analyzers. There'll be different codes which they would have defined. So knowing your analyzer before you really look at the flagging messages becomes equally important. Now, this is a very interesting and an important question, and I open to all of you here, all my students who are in with me today. The question is, in fact, I get this question comes to me pretty often from my colleagues when they ask me, I have 3 possible analyzers which I can pick up. I've assessed all 3 of them. Counts on all the 3 are exactly similar. There's not much of a difference. But when I look at flags, analyzer A gives me no flags. Analyzer B gives me too many flags. And analyzer C gives me just the right flags. Which analyzer should I be opting for? Which is the best one amongst all of them? So what is your thought?
Sir, I think analyzer B, maybe because it is very much sensitive.
So, but it
we
flags
won't
too
miss
much.
any.
But you will have too many slides to make, isn't it? And since there are too many slides, you will obviously not be very happy with it. You have a lot of work to do then.
So I'll
And
go for C then, with
so
just
okay.
flags.
So I'm sure majority of people would prefer to call analyzer C as the best,
Yes.
obviously, because you're getting correct counts and you're getting just right flags. But what is extremely important to realize is there is nothing wrong with analyzer A and analyzer B. They are also actually similar to analyzer C. The only thing is that in this, the flagging has not been what we call optimized. Okay. So if I optimize flagging in A and I optimize flagging in B, and we have already optimized flagging in C, they will work exactly the same way. Okay. So there is no one amongst them which is the best. All 3 are the best. All 3 are good. All 3 have the same potential. but we need to make sure that the first two are handheld. The third one, the company has handled it very nicely. So you get my point. So there is no difference
Yes, sir.
between the three analyzers. That's why I talked about flagging in terms of analyzer optimization. So I'll show you in my subsequent slides how this becomes important. Okay, so now when we talk about flagging, and I'm now concerned primarily about analyzer A and analyzer B, because C, the company guy, has already done his job very well. So I'm concerned about A and B. So in A and B, there is this thing called flagging setup. Okay, and different analyzers will have a different name for flagging setup. This one, which I'm showing you, is from an instrument of a company called Mindray, which has an instrument, the one which I'm showing you here. This is from one of the previous instruments that we had, that's 6800 when it was started in our setup. And now you see what happens is there is a threshold at which you set a flag. Okay. Now, company by default sets it up at a certain point. For example, if you look at this picture which you're seeing in front of you, it shows everything has been set at a numerical value of 40. So anything which will pass beyond 40, you will get a flag. For example, in this case, this red one which you're getting here is at 40, it has gone beyond 40. This tells you that this is an abnormal lymph or a blast. Okay. Whereas when you see here, on an infected RBC1, the flagging has been reduced, not to from 40, it has gone down to about 32 odd. Okay, so the point what I'm trying to make is this activity, which is supposed to be done in this analyzer or any analyzer for that matter, should be done by the people who are actually operating the analyzer, and by that I mean you and me. The ones, for example, in my lab, I am involved in making sure that my flagging is optimal for my system. So this is called flag optimization and needs to be done by everyone. And remember, and I'm sure if you would all realize, most of the cells or the dots that you get on your scatter plots actually are associated with a number on X, Y, and Z axes. And these numbers will have different, and the variability, the scales will be different in different analyzers. For example, if you look at Sysmax, you have a scale of 0 to 300. On Mindray, you have a scale of 0 to 100. And if you look at the analyzer companies, they will set it at a default at a certain number. So I showed you here, the analyzer here had been set at a default of 40. But when you look at my, infected RBCs, I had reduced it down to about 32. So why? Because we figured out that, at that one, it's able to get me just the right optimization for getting me a good threshold of 50 parasites per microliter. And I'm able to find it out very easily from the instrument itself. So just to give you a look of flag optimization, there are morphological Q flag values. This is for Sysmex. So you have blast, immature grams, left shift, etc., which can be given. Default is 100. But for example, in this case, the modification had been done at all these numbers. So you have to modify these numbers, and all that needs to be done in consonance with the instrument guys, because this whole thing will be done in what is called an administrator mode. Okay, you can't do it on an operator or a user mode. So from a flag, if there is no flag, that means there is no abnormality in the sample. If it's a positive flag, then you will have a specific generated message, which could be, a message which has to be worked up on, or you can have an error message. In any of the positive or the error messages, you have to have some intervention. So if you look at the flagging system, there is a result which has come. The flagging is negative. It will go and directly get reported. Flagging is positive. You will have to review, or an error is there, you will have to review and finally report. And that's what helps you to reduce your slide review rates. And flagging system, as I told you, you can have different kind of positive and error flags. For example, if you look at in differentials, you can have abnormality in cell differential, and the machine can tell you that there is an abnormality in cell differential. It can tell you that there is an abnormality in cell morphology. For example, in digital morphology analyzers today, this is a possibility. And in functional, you can have a problem. For example, there is an abnormality with the delta check, or there is low reliability of data because the numerical value which was there was very little, and it was not possible for anyone to use it perfectly. So you have IP data messages, which is otherwise interpretative data messages. And this you have two distinct ones, which I told you previously also, like abnormal and the suspect ones. Abnormal means it's very sure of that particular thing being not the normal, right? Whereas on a suspect part of it, it indicates that there is a possibility of a sample being abnormal. And in such circumstances, you might need to review a smear. Again, you can also have IP messages which can be detected from cell information. For example, there can be higher fluorescence. There can be, for example, if you see an APML, the fluorescence will be very high and the machine will actually pick it up like that. Similarly, you can have problems on forward scatter, scatter plots, histograms, etc. All this needs to be kept in mind. If you look at the white blood cells, you can have distinct abnormal flags. For example, you can have flagging of neutropenia, neutrophilia. Now, these are all definite flags because the instrument is able to correlate with the numbers and give you the values. And based on those values, it's able to identify and define and tell you, yes, it's sure of whatever it is doing. But there are others, for example, the ones which I'm showing you here, the suspect ones, where it is not dead sure about what it is, but it thinks that it probably could be a blast, or it probably thinks it's a left shift, or it probably thinks there is a lymphoid blast or a blast or an atypical lymphocyte. And sometimes you can get resistance of the red cell lysis. So all of these flags are important, and this can come in the WBC plots. Similarly, for RBCs, again, you can have definitive flags like microcytosis, hypochromia, etc., anemia. Whereas in suspect ones, you can get RBC agglutination, etc., which can also be, again, these are not definitive. They are suspecting it, and it may or may not be correct when you're seeing on the smear. Again, coming to platelets, you can have abnormal distribution. You can have specific thrombocytopenia or thrombocytosis, and you can also have suspect ones, which are like clumps or platelets, which need to be identified onto a smear. So now when you look at quantitative monitoring of flagging, as I showed you previously, I'd shown you a cutoff of 40, right, in one of the Mindray analyzers. You can see a cutoff here where it has been kept at 80 or beyond 200. For example, if you keep at 80, you will have a lot of samples which will be highlighted for blasts. But if you keep it about 250, there'll be very few samples which will be highlighted for blasts. So you have to put it correctly and optimally for your instrument. And for example, in this case, they eventually put it at 100 and they got the right values in majority of their samples. So it's not perfect at 100 in the sense that it will not be 100%, foolproof mechanism, but it will not miss any case and it will not give you a rate which is too high for you to handle in your system. So that's what you have to keep in your mind. And that's when you are able to actually ensure that your trigger level is correct or not. And this needs to be defined in your instrument on your own. So Q flagging system, as I showed you previously, is the same picture actually. The Q flagging system in both of them is dependent upon you, and you need to define your thresholds for whatever you are trying to get a flag for. Now, coming to the question for my folks, the students who are with me today, flagging on a cell counter is defined on the counter in an administrator mode. It will need customization at the user end. Once defined and validated, needs to be applied for the sample mode or all of the above. Answers? So somebody has already
Sir, I think
answered.
all of the above.
Yeah, so that would be the easiest answer to give because whenever you have a choice of all of the above, most of the times the answer will be all of the above. But the fact of the matter is I have already dealt with what I just showed you. So therefore, in this case, yes, all of the above is the answer for flagging. Okay, so all of the above is the answer. And you must also remember that when we, look at our instrument, we must know what are our linearity limits. It's extremely important for us to remember. For example, the linearity limits which I'm showing you here, these are for the Coulter analyzers, for the WBCs. Why am I wanting to know my linearity limits is because if I have a sample which is giving me a value of say 99.99 and beyond, or maybe 150, now this 150 may not be true. It may actually maybe 200 or 300 because my linearity has been much beyond the numbers that I got here. And therefore my counts may not be reliable. So knowing about linearity limits is also very, very important. It may not sound as a correct direct flag, but it is a kind of a flag which one needs to keep in mind. Okay. So I'll now change gears a little and I'll take you back the memory lane for about 15 odd years back. Way back in November 2011, I was in this place of work and I had my final audit for NABL. At that time, the NABL, the standard which we were adopting was ISO 15189 2007 version. And I had the assessor for me was none other than Dr. Sukesh Nair. And he's if I may call him father of hematology analyzer in the country, I will not be exaggerating. So he had come for our assessment and he asked me a very interesting question. He says, this was my analyzer printout at that point of time. and this is what the values were. And he says, Anil, will you make a smear in this case? So obviously, when I looked at this, I said, no, I would not make a smear because everything seems to be okay. And then he says, what will you do in this case now? So when I looked at this case, I saw that my values were like completely off, uh, you know, completely off here. And you had a platelet value which was normal, but then you look at these values and you look at the graphic data, it seemed, completely off. So I said, I'll make a smear in this case. So, and he says, so how does one decide in your system whether you will review or you will not review? And, and that's the time when he gave me a non-conformity and said, you have to do what is called a slide review criteria definition in your laboratory, and to ensure that you do not miss out anything or you do not overburden yourself by doing too many smears to see. And therefore, for that, we need to have what is called rules, and those rules need to be defined for the laboratory. So if I may ask for slide review rules, what is true? And I'm not sure how many of you would be able to answer that, because this is being answered by me in my subsequent slides. The question is, there are 41 in number. They need to be defined by the user and validated, need to be defined by the vendor, are defined by the Hematology Consortium. Answer?
Need to be defined by the user and validated.
Fantastic. So that's what I had not done in my audit at that point of time. And obviously I had to start doing it. And so this is what we did. We needed to define and identify and then proceed further. So remember, when we are identifying the rules, we need to keep in mind that there are certain criteria which have to be defined. We can't just have rules in our minds. We have to understand what is the burden, what will be the cost, not only in terms of, you making more slides or staining more slides, but also the cost in terms of manpower that will be required for, kind of looking at those slides and releasing the reports accordingly. You need to keep in mind the turnaround time and also ensure that there is precision and accuracy of ensuring what we are expected to do. So all these points are important. Now I'll take you to my laboratory's, kind of functioning, and I'll show you how this becomes important in any laboratory, right? Now, if we go by NABL's, system of defining laboratories based on workloads, they define small to medium-sized labs. The ones which are small is less than 100 to 400 is the medium-sized one. And the large-sized labs are more than 500 samples per day, 500 samples a day. And they're, sorry, read this as 500, 400. And they are usually the small and the medium-sized labs are open for a defined period, not a very long time of the day. But large-sized labs usually operate either 24/7 or they operate at least 10 to 12 hours a day. The lab physicians usually in a smaller labs are usually one, generally owned and operated by the same person. And the large labs have a few laboratory physicians, but how many can vary from lab to lab. Now let's look at our hospital. We have about 600 odd samples in 24 hours. And in addition to CBC, we have many other things in the hematology section, because the hematology section not only does routine CBCs, it does coagulation, it does protein electrophoresis, it does flow cytometry, it does marrows, it does lots of other things. So that's why I put this plus here. And how many people do we have on board? We have 2 consultants. Of course, we had 1 registrar. Now we have 2. In fact, now both of them have become consultants. So let's say we have 4 consultants in the system at the moment, right? So, and we have to report 600 samples in 24 hours. And we also have phones ringing. We have our clinicians who are wanting everything more and now. And then you also have people, walking in and wanting to look at the smear parallelly, because we run a DNB hematology course as well. So if you look at the possibility, what should be the technologists, who are there with you, who should be putting in an effort to help you, they should be actually looking at the data, and they should be looking at it in light of the rules and giving you the samples which are only required for you to look at. Otherwise, you will be just wasting your time all the time, right? Now, the question was, how do our technical staff really know the rules? And this is a question which was asked by Dr. Nair also during our, audit at that point of time. So obviously the answer was pretty simple. It's there in the procedure manuals, but that's a fact. Most of us write SOPs, and those SOPs are generally kept on one side of the table. Nobody really follows them. And in reality check, when he asked the technical staff, the fact of the matter was most of them claimed that it was experience or memory, right? So remember, whenever we make these rules, etc., percolation of this down to your entire technical staff becomes equally important. Now, coming back to the scenario in our center, as I said, we have about 600 odd CBCs. If we make all 600 smears and we have 4 authorized signatories, each of us work 8 hours. So we have 32 man hours available for us for reviewing 600 smears. Let's smear, if we look at a smear ideally, I know most of us will not really agree with this point of it, but let's say if we ideally look at a smear from the literature, we need 10 minutes for each smear. So that means for our 600 smears, we need about 6,000 minutes, which is about 100 hours. But we have only 32. So there's a huge deficit, which we have to really cover, and it's not possible for us to cover that at all. So therefore, slide review rate becomes an important aspect for us to keep in mind. Now, manual review, as long as we just leave it to our technical staff, it will be dependent on what is called individual decisions, individual performance, variness factor, and there'll be a lot of individual inconsistencies in it. And that's why automated decision rule making is very important. It can also lead eventually to auto verification, and we'll talk about that a little later. We'll also talk about reflex testing wherever it is required, and it'll probably be applicable to certain labs where we have good laboratory information system, and of course it affects our quality as well. Now, when we talk about validation or verification or authorization process, what are we looking at? We need to look at reviewing of the QC run. We need to look at the analyzer performance, which we are already dealing with. We would also want to do a delta check. That means go backwards and see, did the patient's earlier samples give us certain values? And we would also want to make sure that there is nothing pre-analytical, which is going to be, affecting our test results. And then compare the related test results. For example, if I have a CBC showing me iron deficiency and I have the possibility of looking at iron deficiency in terms of the serum values, I would like to look at that parallelly as well. So after you do an automated CBC and your differential counts have been produced in front of you, especially in a 5-part differential counter, you would want to review and verify the report. Sometimes you might want to examine the smear and do a manual visual differential counts and maybe also do other tests. So for a review, what is important is you want to reduce the number of samples you require to review to the greatest possible extent, and that would be the best thing to happen. But in the best of the centers, people are not really able to get it down to less than 50%, right? Remember, analyzers, especially today with 5-part analyzers, sometimes people say 7-part or 10-part analyzers, they are very, very, very good analyzers. They're able to do a lot of good work, which you don't need to really spend your time on. We must remember humans are smart, but they are slow. And of course, higher labor costs internationally. So it becomes difficult for a lot of people to handle the review part of it by a pathologist. And of course, you can also have false positives, which will give you more work, and false negatives from the analysis, which can harm the patient. So you have to be very careful about these principles before you really ensure the slide review rates are taken care of. So how do you review? What is safe? What is the most effective? How do we know? And is one's lab experience enough for us to get into this area? So for this, there is something called criteria for review, which was given by ISLH. And the inspiration was Dr. Bernard Heuben, who was the founder of ISLH many, many, many years ago. And they came out with this concept of slide review criteria. I'm not sure how many of you have been through this, but this is one thing which I would strongly recommend all of you to read up. So what do we have here? The criteria was developed by ISLH way back in early 2000s, where they decided to set a functional guidelines for defining what is the slide review criteria. And this paper would eventually aid the laboratories to look at slide reviews as how to do this. And there should be no loss of useful clinical data. Now, this was done in California way back in 2002, and these were the hospitals which were involved. And interestingly, if you notice, none of them from the eastern part of the world. So everything, the western side of the world actually decided to do what they did. And as they said, there were 2 days of deliberations, 20 hematologists, over 200 sodas, teas, and coffees, and finally they came out with 2,000 rules. Can you imagine 2,000 rules? It's not possible for anyone to actually handle so many rules to take care of. But eventually what came out was nothing but an international consensus, which came for a slide review criteria and followed the CBC counts and gave us the values from this paper. Just give me a second now. Okay, so This was the protocol. They took at thousands patient specimens from their daily workload over several days, and they looked at, as I said previously, about 200 specimens, recorded all analyzer data, reviewed the smears, rule performances, etc., and found out individual laboratory rules. And these were the analyzers which were used for defining the slide review criteria for at that point of time in 2002. And just to give you the kind of the bottom line from what was the definition of a positive smear finding, you had morphology for RBCs, platelets, platelet clumps, toxic change, etc. And then you had abnormal cell types which were picked up. Now this was like you were looking at the smear and then you were looking at the data coming from the hematology analyzer also at the same time. So eventually what happened, they gave us the rules which were put into 5 main categories: the WBCs, the platelets, the RBC and the hemoglobin, and of course the differential parameters where they had suspect flags, including the neonatal first-time samples and subsequent samples. And they eventually gave you 41 consensus rules, okay? But it is not necessary that all of us need to have the same rules or use the same rules at all the times, okay? So these are some of the rules which have come from the ISLH part of it. You had a WBC of more than 4 and less than 11,000 with WBC flag. Similarly, so many other rules. I'll not get into details of this. Again, neutrophil, absolute count of less than 1,000. If it's coming for the first time, they would do a review, or immature granulocyte flag, or an NRBC flag, or an atypical lymph flag, etc. Again, for platelets, you had less than 100,000 for the first time, they would review. And then if there were no flags, but within this, they would verify, So all these were kind of defined in the slide review rules. Again, for RBCs, hemoglobin for less than 7 for the first time, a slide review would be done. Similarly, an MCV of more than 100 or MCV of less than 75. And if there were no pass of delta in all these conditions, the review would be done. So what did we do in our center? This was the team who actually helped us to sit down. And of course, a smart man like me had a lot of hair at that point of time in my head. And we looked at so many rules. We defined these slide review rules. Again, this had come as a part of our non-conformity, which I already told you. And these were the number of specimens at that point of time of day that we were doing. And we got, we just took one whole week's samples and we looked at how the rule was working. So if we look at the methodology, what did we do? We looked at the defined rule and we looked at the status of the smear and we graded it. So if there was a refined rule which was triggered and the smear was also showing us a positive finding, that means it was a true positive one. If the rule was triggered but there was no positive finding, that means it was false positive. If the rule was not triggered but there was a positive finding on the smear, it was false negative. And again, a defined rule was not triggered, but no positive finding, that means was a true negative. So basically a truth table was created using true positive, false negative, true negative. And we looked at the various samples for that particular date at that point of time and figured out what was our false positive and false negative. Our main worry was the false negative part of it. We wouldn't want to miss these. And this was 1.878% in our study at that point of time, which was much below the criteria that was given across by ISLH at that point of time. And it still holds true because even today, the criteria is less than 5% should be false negatives. So this is where we stood at that point of time. And as you can notice here, less than 1.79% of false negatives in our center. And false negatives are primarily due to a delta check, which was ignored by a tech or a doctor, a left-shifted maturation, which was kind of ignored, a reactive lymphoid cell, which was ignored. In some of them, when there was low density of malarial parasite and instrument couldn't pick up, that time we saw it, and of course in platelet anisocytosis. And false positive rate was mainly due to what is called the suspect flags, because in all suspect flags, we would make a smear. So if you look at the take-home message for this, if one wants accreditation by the NABL, then we need to define, validate, and implement the slide review rules. But that's not the only message I want to give. We must remember, for optimal use of resources, we need to acknowledge that this needs to be done. We need to define our slide review rules. We need to validate them. We need to train the staff, implement, revisit at least once in a year, and ensure that the false negative rates are less than 5%, update any changes in such review, update use of LIMS, and middleware for automated slides. I'm sure most of you would have thought we are sorted and done, but remember, we still have what I call abhi picture baki hai mere dost. This is one thing which we need to remember. In the ISO 15189, in the latest version, right from 2012 onwards, and in 2022 version also, they came up with a very interesting stuff called automated selection and reporting of results. So a quick question again, auto-verification of sample reports needs a defined verification engine on LIS. The reports shall have signatures of the person who defines the engine, usually follows a CLSI guideline auto 10 or all the above. The answer is
All of the above, sir.
absolutely. So whenever we'll have a question like that, all of the above is the answer, and all of the above is the answer for sure. And this is what I'll show you, how it becomes important. This is the CLSI guideline called Auto 10. A stands for approved. So this is an approved Auto 10 verification for clinical laboratory testing. And when you use this, you need to ensure that there are, whenever you try to implement it, most of the people will be, kind of not pro it, and because people will have expectations which might be different than what is expected out of it. And you are actually getting people out of the comfort zones and vendor issues. So whenever you try to implement auto verification, I'm sure most of the people are not willing to get it done. So if you look at it, initially, this is the cycle which most of us go through in real life also, and even when you are putting up the auto verification system. So initially there'll be shock and denial, then there'll be anger, negotiation, depression, testing, and acceptance eventually, right? Just give me a second.
Yeah, Anil. In the meantime, I can share with you for the students.
Sorry, I'm sorry.
No, it's okay. I thought I'll just tell them what is ISO and 15189 and 112. It's okay. Over to you.
Okay. Sorry. So the thing is that whenever you try to do auto verification and implement it into your system, these are the various stages which everyone goes through. This is a normal life pattern for anyone for that matter. But however, at the end of the day, we eventually accept it and we move on. And that's the story which happens for auto verification as well. So what do we do in this case? We have to plan, we have to act, we have to check, and we have to do. And that's what is called a PDCA cycle. And that's what is followed. So you define an auto verification engine, but who defines it? We define it. The person who's actually using the instrument, he defines the auto verification engine. It is defined by lots of things. You can define it on pre-analytical information. You can define it on the analytical information or a combination of both. And then you can identify whether they will go directly for auto-verified results or they will have any manual intervention. And this entire concept works on the same principle. You can have a complexity of the rules which can make it work the way I'm showing you. You can have an input data, and with each data you can have variables, just as the way you put it into an Excel sheet, and then finally get into either auto verification or rejection of auto verification and putting through the manual results. So if you look at the clinical laboratory reporting system, the analytical phase part of the clinical laboratory testing, you have to have what is called a biological plausibility by the automatic expert system, which is what you will define in a middleware. And if it gets highlighted, you might need to reevaluate the pre-analytical variables and the analytical performance. You might even need to evaluate the lab physician. If this plausible gets activated by the expert system, you need to get a validated report immediately. Otherwise, the entire concept goes through a non-plausible system, and it moves to the final transmission of the lab report. So the final take-home message is auto verification is a process which is possible with almost all the modern day analyzers. And the ability to auto verify is a high percentage of results, increases the productivity, it reduces the turnaround time, it reduces manual review and further investigations at time. It gives you a paperless environment, additional capacity to add new testing without adding a new staff, reduces opportunities for error, and standardized sample and data workflow. Thank you very much for your kind attention, and I'll be happy to take questions. These are various papers which I have been through in terms of preparing this presentation. And just to remember that it's the man behind the machine who matters the most. So you must make sure that you are, kind of in love with your instrument. You should know your appropriate process workflow before you actually adapt to the instrument and make it work. And thanks once again to my lovely team at my workplace. And thanks for your kind attention.
Thank you so much, sir. There's no question in the chat box. And it was such an excellent lecture. And thank you so much for enlightening us with your immense knowledge, sir.
Thank you.
Anil, you have anything else to mention? Any final comments or?
No, I think the important comment which I would want to make here is, the biggest problem let me look at myself, when I actually got into pathology and eventually got into hematology analyzer as an instrument, we only look at it to give us the hemoglobin value, the platelet value, and the total leukocyte count value, which is an unfortunate thing to happen because this analyzer has a huge possibility of getting information across to you. And you need to be in love with your instrument to understand your instrument very well, just like your partner, and make sure that you extract the best out of it to give the best possible result to the patient. The second point which I want to emphasize on, which I emphasized during my presentation as well, it is not the responsibility of the company guy alone to make sure that your instrument works the way you want the instrument to work. It's also equally your responsibility to ensure and extract that kind of a output from the analyzer and make the company guy work for you accordingly. And at the same time, ensure that you're getting all the things kind of sorted through the analyzer modes. And finally, when you're setting up the entire assay for your system, make sure that your criteria are met with appropriately. Otherwise, you're only going to create more problems for yourself and not depend, and you'll obviously not depend on the analyzer. You'll say, oh, it's a useless thing. We shouldn't really depend so much on the analyzer. So, make it work good for yourself and for your laboratory as well.
I remember, Anil, you came to our lab, I think maybe 10 years back or 15 years back for an audit. And we were doing that time maybe 1,000 CBCs per day. Now we do almost 1,700. And you asked us about our slide review criteria we didn't have.
Yeah.
So we now, thanks to you and thanks to continuous learning, now we make maybe 200 or 225 peripheral smears per day out of 1,700
Exactly.
CBCs.
Absolutely.
So we have made our own criteria based, our requirements and taking our clinicians' feedback. It really helped. Yeah. There's no questions there. Any comments from my moderators or any students have any questions? Otherwise, is it time for dinner?
No, sir. There is no question in the chat box.
Anil, thank you very much.
Thank you, sir. Thank you. Have a
Thank
good
you,
day.
sir.
Good
Thank you
night,
so much,
everyone.
sir.
Bye-bye. Thank you for
Good night.
being
Thank you,
there.
sir.
Thank you. Bye.